Okay, so good morning. I'll take you to Mongolia ethnographically. The main focus of my article, entitled Natural Calamities and the Big Migration, Challenges to the Mongolian Health System in the Age of the Market, a very long title. It is to critically examine Mongolia's health system and to discuss the extent to which this system, despite its provision of universal accessible, essentially primary healthcare services, is actually unable to accommodate to health needs of poor urban immigrants and nomadic herders in remote provinces. Just give you a map. Not everyone knows where Mongolia is. So Mongolia is situated between Russia and China. That's it. And you have Kazakhstan here in the west. It's 4 times the size of France, very big. At the moment there are 2.9 million people living there, and it's one of the most sparsely populated countries in the world. The capital, Ulaanbaatar, as you can see, is the only city, really real city in Mongolia. And that's where all development happens, apart from in mining in the Gobi Desert. Okay, so as with many other countries in the 1980s and 1990s, Mongolia embarked on a series of structural adjustments and neoliberal health reforms. In fact, it stood out as a star example among the post-socialist nations, according to some foreign economists and consultants, at least. These transitions, they radically changed the state's role in the lives of the then 2.5 million Mongolians, that is in the 1990s. Now, the aim of the external foreign economists and consultants was to establish a market-oriented economy through and through, and along with this process, to create a very weak state. That was one of the aims. So many of the Mongols I've talked to from 1996 until 2013, which have been my fieldwork periods. Many among them, especially the nomadic herders in remote provinces, they convey that they feel the state has abandoned them. It has stopped caring for their well-being, and this in contrast to before, that is during socialism that lasted for 70 years, when the state had been so closely intertwined with their lives, I mean for both good and bad, obviously. And this sense of loss is very significant because it tells of the struggles, the increasing poverty, and the precariousness that many nomadic herders of Mongolia face today. So my article in our special issue aligns these issues with health and the health system itself, and critically discusses how equity in health and Mongolia's emphasis on health for all is hampered by a very narrow focus on the technicalities and management structures in seeking to strengthen the health system. So I thus argue that the process of health system strengthening in Mongolia requires a more comprehensive focus on the politics and the social relations that shape the health system. And this requires, I believe, a more comprehensive and as Katerini said, a bottom-up understanding of various political, environmental, and demographic factors. Okay. So, in other words, to understand how health service delivery in Mongolia is organized and performed and how to proceed in strengthening the health system, I think it's really vital that we focus on the ways in which heterogeneous elements are assembled. And by that, I mean that how they are causally interlocked, and the manner in which these elements, in fact, are important factors affecting the workings of the Mongolian health system and its provision of healthcare. So, with a particular focus on recurrent natural calamities, that is winter disasters, really, really harsh winter weather, but also an escalating rural to urban migration, I argue in this article that the issues of access to healthcare services and health system strengthening must be understood in relation to these factors that are seemingly or seen as external to the health system. Now, natural winter disasters and rural to urban migration the past 15 years have contributed to exacerbating lack of access to health services, especially at secondary and tertiary levels of medical care, both in Mongolia's only city, Ulaanbaatar, but also in the rural areas, where as I have told you, the majority are nomadic herders. So what I suggest is that the impact of these factors must be realistically and politically approached in the ongoing process of strengthening the health system. Now, my own and others' ethnographic research on Mongolia highlights that despite a growing economy and considerable external aid, and really an established primary healthcare model, weak rural politics, environmental challenges, and economic constraints create escalating health vulnerability among the poor and the poorest in Mongolia. And this, I suggest, should lead us to consider not only the effects but also the causes of those factors that inflict on the Mongolian health system's ability to provide equitable healthcare for all. Now, in Mongolia, as elsewhere, these factors are very contextual, yet they are also shaped by global dynamics and ideological and political currents within global health policy institutions financing and health intervention strategies. And I'm going to take you to Mongolia. This is a picture of the silent revolution in Ulaanbaatar in 1990. It was clearly a revolution because socialism fell, but it was not violent at all, and it was started by students. The silent revolution in Mongolia in 1990 marked the end, as I said, of 70 years of socialism and the beginning of a process of liberal economic reforms, initiating what is known among the Mongols as the age of the market. Over the course of the past 2 decades, considerable changes have taken place in Mongolia, as in all other post-socialist nations. And these changes have not merely transformed the political and economic landscape of Mongolia, but have also made a very deep impact on the country's demographic profile and the distribution of socioeconomic capital among Mongolians. Mongolia's recent health system reforms provide a very illuminating entry point to understanding the consequences of these transitions for a growing population of disenfranchised poor. Now, within the radically reformed health system, population health and access to affordable healthcare are significantly linked to the socioeconomic disparities as it is elsewhere in the world. And these disparities, they result not solely from the Mongolian state's disinvestment in social security and social services, or from the motions of weakly regulated privatization that have contributed to widening the gap between the rich and the poor. They are also interlinked with the recurrent natural calamities and lack of risk preparedness by the state. And also low quality and or lack of services in the rural areas, as well as the massive one-way migration to the urban area, Ulaanbaatar. And that is what is known as the big migration. Now, since 1990, the earlier centralized socialist health system, known as the Shmasko system, has come to be replaced by a system consisting of a package of essential and complementary healthcare services. The former providing free of charge primary healthcare, the latter covered by health insurance through the National Health Insurance Fund, which was initiated and supported by foreign donor organizations and development banks in cooperation with the Mongolian government. Anyway, I'll start that over again. So initiated and supported by foreign donor organizations and development banks in cooperation with the Mongolian government, the health system in Mongolia has explicitly been shaped on basis of principles of equity and social justice. Yet these basic principles have not been implemented. The coupling of privatization of the secondary and tertiary levels of healthcare and a limited essential primary healthcare, as well as very high levels of referral from primary to secondary and tertiary levels of care, have in fact produced a very fragmented system of healthcare services. Now, the drastic macroeconomic reforms that took place in Mongolia in the early 1990s were characterized by shock therapy, aimed at speedily dissolving the socialist past. Now, given the social and economic chaos that followed in its wake, in retrospect, it seems very clear that shock took precedence over therapy. Now, this rapid transition implied a demolition and literally overnight of the social support system and also withdrawal of comprehensive state subsidies during socialism. So, backed by substantial loans, aid and advice from foreign donors, especially the World Bank and IMF, Mongolia adopted fully the package of structural adjustment policies imposed by their donors. The neoliberal incentives implemented by the government in the early 1990s has clearly not been favorable for the majority of the herders in Mongolia. The severity of poverty remains a critical issue in the reformed Mongolia, and especially among those most disenfranchised. Oh, that was a bit unclear. Now, during the socialist era, the state managed and provided most necessities through the collectives and state subsidies. An extensive intersectorial organization provided for a certain flow of work tasks that enabled a quite efficient allocation of the workforce. Now, the costs, however, of running such a system were great. So without economic input from the Soviet, it would not have been sustainable. And this became very evident with the withdrawal of Soviet support after the demise of the USSR. Now, the economic reforms that took place in the 1990s in Mongolia, along with the abrupt withdrawal of Soviet subsidies, then amounting to 30% of the GDP, contributed to a considerable deterioration of the health sector. So with a decrease in health expenditure and the ensuing withering of the health infrastructure, Mongolians were left with a health system that could not provide adequate essential health care. So herder families in rural areas, they were the most severely affected at the time in the 1990s, and that was due to several factors. It was lack of doctors, because many of them just left because they were not paid any salaries. It was shortages of medicines and equipment fell, into disrepair. There was closing of almost all maternity wards or waiting homes for the nomadic women, and there was also an ad hoc introduction of user fees that demanded cash that very, very few had access to. Now, this shift towards a liberalization of the health sector took place gradually from 1991, with IMF and the World Bank as dominant actors in terms of recommendations and financial guarantees. And grants and loans were provided on the condition that the Mongolian state carried out drastic neoliberal macroeconomic reforms. So with technical advice and funding, the Asian Development Bank, in cooperation with the Mongolian government, initiated a comprehensive health sector development program in 1999. And this reform involved the provision of free primary healthcare services through the private family group practice, the FGP, that serves a given geographical location or population in a sort of sub-district. In the cities or in the province centers in the countryside. And they are paid per capita, on per capita basis, adjusted, and is also adjusted by the socioeconomic status of the patients and community risk. Now, furthermore, a compulsory national social health insurance system was also introduced in 1994, and this social health insurance covers vulnerable groups fully, such as children under 5, disabled, adolescents, pensioners, and pregnant women. Before 2006, however, uninsured persons were not able to receive primary, secondary, or tertiary care. Presently, primary health care is available to all, regardless of health insurance, while secondary and tertiary hospital care and diagnostic testing requires 10% and 50% co-payment, respectively. And those without health insurance, they pay the full cost of care. In Mongolia, transportation, this is big, transportation also requires payment. Moreover, in most cases, out-of-pocket payments are required for drugs and medical supplies, which at state hospitals are meant to be free, as well as, but they aren't, as well as gifts and briberies to medical personnel. Among the very poor, 94% of out-of-pocket payments are spent on pharmaceuticals. And in 2010, out-of-pocket payments accounted for 41.4% of Mongolia's total health expenditure. Mongolia struggles with corruption at all levels of society, and clearly the health sector is no exception. Okay, so formal registration of residency is a prerequisite for obtaining health insurance in Mongolia, which again provides access to all levels of healthcare. Now, for the poorest immigrants, acquiring the registration documents is the first of the many bottlenecks they encounter when arriving from the countryside to Ulaanbaatar. Attaining registration documents is often hampered by barriers in bureaucracy, the cost of the sort of gifts to civil servants that they demand for processing their application, and for the poorest people, the actual price of paying the registration. Now, these barriers are particularly relevant to recent immigrants to Ulaanbaatar. And the consequences is that poor, unregistered migrants either refrain from seeking healthcare or take up huge loans to cover their expenses, and which usually takes a lifetime to pay back. Now, both WHO and the Mongolian Ministry of Health recognize the deficiencies of the public health system and are currently pursuing initiatives to strengthen the health sector. And one of the outlined strategies of WHO is to support emergency and disaster preparedness, including health emergency preparedness during, for example, extreme winter calamities, also known as ZOD. Now, a winter calamity, ZOD, is one of the several factors that pose a challenge to the already precarious lives of many nomadic Kurds in Mongolia. ZOD is a composite local term for a range of different hazards that occur during winter as a result of extreme, and we're talking extreme winter conditions down to -55. Now, due to freezing temperatures in winter and ice-crusted snow on the pastures or heavy snowfalls, animals are prevented from grazing, which results in very high livestock mortalities. Now, ZOD is also threatening to the herders, who may freeze to death, which happens, be injured while trying to save their animals, or get mortal frostbites. ZOD can last for weeks and can therefore hinder herder families in reaching healthcare services in time, as severe weather conditions they exacerbate the effects of great distances and but also lack of transportation, as people are tied up trying to save their animals. Okay. But significantly, the post-factum effects of ZOD in terms of livestock mortalities have dire consequences in terms of poverty and migration, which again influence both access to and delivery of healthcare for those who end up as immigrants in Ulaanbaatar. The severe consequences of Tsod that occurred in 1993, 1999, 2002, and 2009-2010 explicate the Mongolian state's shortcomings in managing and responding adequately to these disasters. These events left a substantial number of families deprived of all or significant part of their livestock, and many were forced to take up loans they could not repay in order to regenerate the herds, or they sought precarious lives as what they call ninja miners, panning for gold in the informal mining sector. And others just simply gave up herding life and migrated to the city, hoping for a better life, yet most of them ending up in desperate poverty. Now, almost 70, just give me a minute here. I have 4 minutes? Yes, okay. So almost 70% of Ulaanbaatar's population, they live in peri-urban gear districts, that is, tent districts at the fringes of the city. And these areas consist of traditional Mongolian felt tents, as you can see here. Or they also live in badly isolated houses. In the most peripheral areas of the gear districts, basic infrastructure such as water, electricity, and sanitation is absent, and the population density is now so high that it poses a really high risk to people living there. Sogn og Herken, one of the most densely populated peri-urban districts of Ulaanbaatar, had an estimated population of 253,000 people in 2011, and the majority of whom were immigrants. Now, health personnel in this district explain the lack of financing, and too many patients create a working environment that is fraught with distress and anxiety of being blamed for fatal outcomes. A doctor described the work burden resulting from in-migration this way. I've been working as a doctor for 18 years in this sub-district. We have 2 doctors working here, and we used to cater for 8,000 people. Due to high immigration, the past 10 years, we now cater for 20,000 people, and we are still only 2 doctors working. So the gap between health resources, both in terms of qualified personnel and funding, and the acceleration of urban poor immigrant is too wide. And this creates poor health service delivery and high levels of referral, but also sustains a lack of incentive for the doctors to care for those outside the system. So the big migration creates overworked health personnel in the gear district, but most importantly, it creates a growing population of vulnerable poor that will become losers, not only in Mongolia's age of the market, but also within the neoliberal health reform. Okay, so I'll conclude. Do I have time for conclusion? Okay. So while WH's strategic agenda explicitly states that health system strengthening in Mongolia must involve a focus on and in response to the rapidly increasing one-way migration to urban areas or urban area, there is little to suggest that the conditions and problems that arise from these major demographic change and their effect on health equity may be solved within the next decade. And such a solution, I suggest, would require a shift in politics through an emphasis on social politics that includes supporting the livelihoods of mobile pastoralists in rural Mongolia. It furthermore requires attention to migration and natural calamities as not merely conditions, but as problems that must be aligned with concrete policies and strategies concerning health system strengthening in Mongolia. Now, the Ministry of Health in Mongolia have embraced WH Country Cooperation Strategy 2010-2015, and their emphasis on holistic health system approach. Yet, such a holism requires that local factors and global actors are aligned and moved onto the political agenda in Mongolia. And consequently, this also involves rural politics that take seriously the sustainability of pastoral production, which further involve emphasizing disaster preparedness and not merely depend post factum on emergency assistance from international aid organizations when a winter calamity occur. Now, I'll soon finish now. So the decline of the welfare state in Mongolia, along with neoliberal incentive, has come to exacerbate socioeconomic and health inequalities in Mongolia. So directing our attention to what Coburn has referred to as the causal pathways involved in inequality in inequality health status relationship provides us with both a contextual and a comprehensive understanding. And this should lead us, as I pointed out in the beginning, to consider not only the effects, but also the causes of those factors that, in fact, inflict on a health system's ability to provide equitable healthcare for all. So I suggest that not taking seriously the social nature of illness, as well as the contextual causes of illness within the present neoliberal reformed health system, will serve to weaken rather than strengthening the objective of equity implicit in the present health system strengthening in Mongolia. Thank you. Sorry, a bit rushed.